Thank you so much, Professor Becker, for a wonderful overview and a really stirring call to action. It's a very easy job to chair this session because we have one speaker after another who really needs no introduction. But at the risk of being superfluous, it's a great pleasure again to welcome Professor Brian Gazzard, known to so many of you for his work at Chelsea and Westminster, where he established the first HIV unit and established a great tradition of clinical research, and now his role as Professor of HIV Medicine at Imperial College in London. It's a great honour. Thanks so much.
I have to say it's now for something completely different. I arrive here, but the slides don't. The slides have partly arrived and partly not, and they're in a random order. So I thought I'd keep you all awake by you guessing which order they should have been in. This is the best obituary of David that I read, actually, and it was in the LBTQ Wanstead Journal. I obviously don't read that very often, not because of the LBTQ context, but because I don't live in Wanstead. But I did think it was a very clever analogy of what David really is, a brilliant mind, but a compassionate soul. Hello, are you still having lunch? Oh. There we go. I think there have been a lot of airbrushed pictures, haven't there, of David over the last few days, so I thought I'd show something real. This is David after his second glass of Cloudy Bay, which was his favourite wine. He always brought 3 bottles when he came to our house, and they were all empty by the time we had finished. We used to go to the garden for our bonding cigarette, both in the naive belief that neither my wife nor David's knew about the bonding. But I do think that eulogies apart, what's been perhaps a bit missing in the last few days is that David was a lovely, lovely, lovely man who was a great friend, and great fun to be with. I knew him very well, and I must say that the first thing I would say about him is that he was unbelievably fond of his family. I had to sit and listen for hours to how important swimwear fashion was in Australia. I was aware that the anchor that allowed him to travel was at home, keeping the family together, and he would interrupt most conversations to have a quick word with Dorrie. He was actually often prouder of the applause that Dorrie got at the end of his lectures for what were brilliant slides in the days when brilliant slides weren't available to all. He was also very proud of his origins. We were sitting at Chelsea Westminster one day supposedly discussing science, and he said, "Come with me," and he'd found a wizened old man who opened a gate at the back of the Brompton Hospital where there was a 15th century Jewish cemetery. And we spent 2 hours, believe it or not, going round this Jewish cemetery with David sorting out where these people were likely to be born, and he could tell me usually what the occupation of the people was as well. It comes as some surprise to me that Cal Cohen almost certainly comes from a priestly religious family, leaving that aside. Because of my own Polish connections, he and I discussed Eastern Europe endlessly, and he was very knowledgeable. But he was, after all, an Australian, and immensely proud to be so, and was one of your most wonderful ambassadors. I actually was in Sydney Opera House very shortly after he got his AO, and it's like the Masons, isn't it, the AO? I mean, it's a bit different, but there's this sort of funny little thing in the lapel here that, you know, makes you recognize each other, and David spent most of the evening going round peering at other people's lapels and having an interactive conversation about what was only then an AO but is now an AC, is that right? I've got a CBE, which means, no, I don't know what it means. Commander of the British Empire, so it means I'm important when I go to the Falkland Islands, but nowhere else. And of course, he was an unbelievably compassionate man who was a good clinical scientist and just a wonderful person. So let's move. Oh, there's some sort of problem here. That's me. I'm just hopeless. Now, just a word of advice to the junior people here. If you want to get grant money, just mention HIV cure. You don't have to understand it, and there's no possibility it will occur, of course, and mention that there are increased comorbidities associated with HIV. Also entirely untrue. You needn't listen to what Paddy's got to say later. But again, it's a good way to get grant money. You don't have to understand it, but if you want the Nobel Prize, this is Linnaeus Pauling, don't read the literature, don't believe what anybody else has said, start from the beginning. And the beginning, actually, for aging is this funny little old lady here who was presented in about 1990, I suppose, in the Italian AIDS Society by an eminent professor of endocrinology who passed rather rapidly through HIV and got interested in other things. And this was a patient who actually, in fact, almost certainly had adult onset progeria. Nothing to do with her HIV status, but he presented this case and said that, you know, we were all going to have to face the issue that everybody would be like this very soon. I was always a very statesman-like person, so I stood up and said very politely, I'm a bit surprised with my 12,000 patient cohort. I've not seen anybody like this. Has anybody else in the audience? And there was a prolonged silence, and I'm still waiting for a response some 20 years later. Clearly, HIV-positive patients age prematurely if they're not treated. This young man ran a magazine called Her, which was the equivalent of the gay magazine for women. And whenever he couldn't find a centerfold, he was good-looking enough to appear himself in the paper. But look, that's 6 months after his HIV was diagnosed. He'd gone grey. His skin was described as that of a 90-year-old, and his immune system similarly as a 90-year-old. So there is no doubt that HIV is associated with aging if you don't treat it. But that's really not the question, is it? The question is really, doctor, if I am good and take my treatment, will I dement? Will I get premature aging? Will I get premature atheroma, etc.? Now, David was very good at asking me to give rather awkward talks. So he asked me at Durban, for example, to give the talk immediately before Nelson Mandela to report on track B. I got the atmosphere entirely wrong because I was rather impressed in Durban that I thought for the first time ever the pharmaceutical companies were doing a great thing and stepping up to the plate for the first time, said so in public and was loudly booed. I then came here and David asked me to give a talk about aging and said, by the way, Bruce Brew will be in the audience, so talk about tau and fibrillary plates and things like that, won't you? I don't know what the hell they were, but I did, look them up a bit and realized they were totally irrelevant to the subject, but thought I ought to talk about it. So this is my return, a very honest talk about the whole subject of aging. I was also asked to give a talk here about PrEP in the very early days when I was an enthusiast and was absolutely slaughtered by the community who still felt that other behavioural methods were important. But life has changed. So, let me be clear, there is no evidence whatsoever for people who take HIV treatment that there is premature aging in that population. They live just as well as you or I. And I'm really just going to talk, I'm not going to go through the data, I just really want to talk and tell you, young people, the elders can ignore it because they've managed to have a very successful career by ignoring it, but there are certain scientific issues that I think that this whole controversy brings up which are important. So we're going to go through those. This is the first of them, is clinical significance. So if you have angina, your risk of, you are all told to take aspirin because the relative risk reduction over a 10-year period for death is 30%. This data was first presented, I'm name dropping now, when I was sitting with Paul Janssen, and Paul Janssen said, the trouble is with this data that the absolute risk reduction is tiny. You know, 95% of people live on aspirin, 93% if you don't take it. Would you really take aspirin for 10 years on the basis of a 2% reduction in risk? But we all use all the time relative risk. So is there may there be a tiny change in relative risk of aging? Yes, there may be. But is it a major clinical issue? Of course it's not. That was a dogmatic comment, wasn't it? That's good. The second, I think, important issue is our reliance on cohort studies. Now, we rely on cohort studies primarily, don't we, to increase our CV, rather than to learn the truth. I learned this lesson some years ago now when our unit produced an excellent epidemiological cohort study showing that favirenz was better than nevarapin. The following year, somebody else doing their MD produced a paper which I had to agree to get published that nevarapin was better than favirenz. All in 2 years, and of course the confounding variables were the geographical time, we were getting better at treating people, and we were using a different backbone. But the trouble with, so we gave up cohort studies. You won't have seen a cohort study from our unit for some years now, because I think they are so biased by missing events, by channeling, by lead and lag time, by whether they're opened or closed, missing events, etc. And we are very misled if we believe them too much. Do aged patients die prematurely? The answer is they don't. The best cohort study, and the only one you should ever believe, is really the cohort study from Denmark. Denmark is amazing. You can't leave Denmark for more than a week without informing the police, and it all goes to a central registry. When you come back, you have to report to the police again, and there's another central registry. Every disease that you've got has got a central registry, so they have no missing patients, all right? And they were the first to show this very, very important graph, that if you take somebody, which is a minority of people, who are HIV positive and have no other risk factors, you live an identical lifespan to the general population. As soon as you've got extra morbidities, hep C, being poor, being ignorant, not going to university, whatever it may be, your survival is less good. But let's be clear that that's nothing to do with HIV, that's to do with the risk factors that create the situation for HIV. The next problem is controls. As you know, I did, like David did, an immunology further qualification, and what you do for controls is take some sweet laboratory technicians who've never had sex with anybody because they're too young and they're not married, have never used drugs or of any sort because they're lab technicians, they don't believe in ecstasy or anything like that. They're nice, lovely people, and you compare those with the rogues who've all got HIV, and you believe that the differences will be significant. So the cohorts are really important. The controls are really important problems, and it's only when you start looking at the appropriate controls that you start to see what the real differences are or are not. So one of the studies we've been doing recently in Dean Street, which has been destroyed, of course, by PrEP, is that we were taking all the people who were coming once a week to have their HIV test, clearly at high risk, but remained negative for a while, and seeing what differences there really were between these people who were at high risk of becoming HIV infected and the people who were actually infected. And then the differences are actually very modest. This is the first of my missing slides. This is TBAS's data showing the increased risk of bone thinning if you are HIV positive. Now, then, if you do the appropriate control, which was so in the IPREX study, they actually, before they started on treatment, all had, they were at risk of HIV, which is why they were in the study, but they didn't have it. There you saw a very similar rate of bone mineral thinning in an HIV-negative population, but who were at high risk. And the reasons for that are obvious. They smoke. One or two of them, I gathered, smoked that illicit substance marijuana, and a lot of them were therefore osteopenic before they start. Nothing to do with HIV, to do with the risk factors that lead to HIV acquisition. This study is the Charter study, and I'm sorry it's again not come out. I mean, frankly, I was a little upset when it was first presented. This was first presented that there was going to be a major epidemic of neurocognitive dysfunction in HIV populations. Now, the people at Charter got lots and lots of money, to investigate this further, very important subject. But when this data was presented, somebody was asked, actually, from the audience, excuse me, did you control for HIV viral load? And the guy said, oh, no, not yet. In parentheses, he didn't actually say that. We need another grant first. But, of course, the problem was that this study was largely people who had untrammeled HIV infection who weren't controlled with the drugs and didn't take the drugs. So dementia is a very difficult problem. The first thing is, how do you measure it? One of my poor PhD students quite recently had his PhD turned down at Cambridge because they said he'd measured dementia in the wrong way. That caused a hell of a hullabaloo. I wrote, to the Regis professor, which is what you have to write to if you wish to complain about the thesis. And eventually we got sort of 4 more psychologists to discuss how you measure dementia. And they couldn't agree, but the Regis professor said, well, as they can't agree, how can we expect the poor student to have got it all right in the first place? So he got his PhD in the end. But it's very difficult to measure, that's the first thing. The second thing is, let's be clear, all the randomized studies that have been done, led often by Alan Winston, who was nurtured here when I thought he would go and have a good time in Australia. When I sent him here, he in fact worked very hard, and David made him produce lots of papers. He's one of the leaders who's shown that actually in all randomized trials, dementia improves, not gets worse on treatment. So that's a big problem. The next big problem we showed, amongst many others, of course, is that most people who claim that they've got dementia are actually just a little stressed, anxious, depressed, or in common parlance, a little mad. And so we referred 150 consecutive patients. They all had very high depression and anxiety scores, and none were actually psychologically demented. We don't know what the role of recreational drugs are, do we? It's obviously illegal to take heroin and then do what psychiatric, but you must believe that recreational drugs might be really rather important. And the whole Charter study, of course, was very biased by the fact that they took many people who were very late in disease. When the CD4 count is low, clearly it's understandable there will be structural abnormalities. What about we all know that myocardial infarction is increased in HIV. Accepted, isn't it? Everybody knows that. I mean, that's not true either, is it, when it comes to it? If you look at all, I'm sorry, this is now, you can't read it, but the reality is, so you don't need to read it, you have to believe me, that's what science is all about. You don't look at the data yourself. The reality is that 80% of people who are HIV positive smoke. 80% of people have lifestyles which are conducive to myocardial infarction. To pretend it's all to do with HIV is dishonest, really. So, where we have, this is, I think, the best slide of all this. This is the mothers of HIV patients and the mothers of control subjects, again from the Danish study. Now, the mothers are not HIV positive, all right, but just like their children, they eat Mars bars, they have lifestyles of sedentary, like a rather large number of my colleagues in the audience and me, taking insufficient exercise and rather too much bonding Cloudy Bay. And so the mothers are all, so it's both genetic and lifestyle issues, and it's nothing to do with the HIV at all. Interestingly, in the SMART study, the START study, you'll do anything to write a paper, won't you? This is a paper we wrote with all the cardiologists, showing that the one thing that didn't get better with early treatment was the cardiovascular risk, which wasn't significant, so don't look at that data too closely, but there was certainly a trend, wasn't there, by year 4, that there was an increased hazard ratio for cardiac problems when you were on treatment, and the reason may or may not have been the rather minor changes in the metabolic issues associated presumably with therapy. Whatever the truth about the minor differences is, what is clear, and that goes back to what Linda was saying earlier, if only we paid more attention to telling our patients to stop smoking, we would have a much more profound effect on the myocardial risk than anything we might do in the research sphere. And of course, that is now in our hands. Vaping is a wonderful way of stopping smoking. It certainly made me stop smoking quite quickly. It's so disgusting to go outside and in the cold and smoke those long, horrible, chimneys that you think, well, I'd rather give up. So it was the first time I ever gave up. So we all have that in our hands to do. I think free vaping apparatus should be available in all HIV clinics. That would be my solution to the problem. And as you can see from this graph, we would have a much bigger effect than anything we can do within HIV itself. What about cancer? Everybody's going to die of cancer as well, aren't they? The number of cancers in SMART were actually very small over a 5-year period, all right? And Jens will only answer this question very reluctantly, but the chief driver of SMART was actually, START, was actually Kaposi's sarcoma, all right? So 11 got it on the deferred treatment, only 1 in the immediate arm. When you ask Jens, actually, what happens when you treat the patient? Oh, the Kaposi's sarcoma all got better. All right, so the entire I'm in favour of early treatment, and I'm in favour of early treatment, as David used to say, primarily because in the third world, developing countries, it's much easier just to give everybody treatment, so this is a very good advertising. But the reality is you're preventing Kaposi's sarcoma, an entirely treatable condition, and interestingly, you are reducing the risk of lymphoma. But there isn't a widespread number of cancers that are, of major importance. One of the difficulties is this very simple slide, which was in the Annals some years ago, that the age distribution of HIV is very different from the age distribution of the general population. And therefore, it's hardly surprising the number of cancers appear commoner in HIV than they do in the controls, simply because of the different age distribution. And in this very good paper, when you actually correct for all that, it's only Kaposi's sarcoma and anal carcinoma and cervical carcinoma that come out any commoner. So bear that in mind as well. Of course, most cancers in the context of HIV are related to co-acquisition of HPV, EBV, etc. So it's very much a virally driven and it's a risk-driven thing, nothing to do, again, with HIV. The final sort of scientific issue that I want to try and get over for you this afternoon is that causation is not the same as association. In the UK now, there's a competition between all universities, for funds, for staff, for junior staff, etc., etc. So that everybody's got a PR department, and the PR department once a month writes round to you and says, have you got anything that's really worth, advertising in the press? And so some nonsense appears almost daily on the Major Today programme in the UK that, coffee is associated with an increased risk of erectile dysfunction, whatever rubbish it may be, because there's a clang association which is thought to be important. It struck me very forcibly today that when I looked around the room with many colleagues and friends who all look a great deal older, there has obviously been an enormous outbreak of HIV infection within the medical community in Sydney. They've all got older. I mean, it must be to do with HIV, mustn't it? So it's a common fallacy which we all use. Here's just an example. It could be anything. This is Steve Deeks. This is early, it's to do with LPS. You all know the story of bacterial translocation. But look at that graph. Half of the people who were progressors had normal activation and the others didn't. And what were the controls? These were, again, lovely technicians who have never done anything wrong in their life and work very hard. And so is that really causative? In our own study of activation, if you look at nice young people who get HIV by mistake, as it were, over a year, the activation markers all go back to normal. I've very nearly finished, I promise. And again, if you look at the people carefully, those with activation markers which are up have concomitant disease. They have syphilis, they have CMV, etc. And even Steve Deeks now agrees with that. And this is the final slide. Here is Steve Deeks showing very clearly that if you give valganciclovir to people who are HIV positive, the degree of activation goes down markedly. I want to just end with this slide. This is the famous Raphael cartoon of Aristotle talking to Plato. That's what I spent a few of my nights sleeplessly here rereading again. And I would like to leave you with the thought that David's soul is eternal. His life will live on through his good works. Thank you for listening.